Hello and welcome to Module 4. My name is Oliver Frenzel and I will be discussing interventions delivered by the pharmacist and opportunities for the practicing pharmacist to reduce opioid-related harm and elevate the well-being of our patient population. Pharmacists are the most accessible healthcare resource in communities across the United States and are extremely well positioned to engage in opioid harm prevention activities for patients receiving opioid medications. We've seen an ever-evolving change in best practices to address the opioid epidemic, which include but are not limited to expansion of opioid-focused curriculum in healthcare programs, CE opportunities to better equip healthcare professionals and bring awareness to strategies in reducing accidental opioid overdose, opioid use disorder education, and also medications for opioid use disorder. And one such example is the One Program screening implementation in community pharmacies. One Program pharmacies have conducted over 25,000 opioid risk screenings since 2018. Of these patient encounters, pharmacists have delivered critical interventions, including explaining benefits and availability of naloxone, dispensing naloxone, discussing opioid use disorder, and discussing accidental overdose risk. Encounters where patients have screened as high risk for either opioid use disorder or opioid overdose, pharmacists have delivered critical interventions to over 97% of these high-risk patients receiving an opioid prescription. This points to a high level of accuracy by pharmacists directly tailoring harm prevention education and interventions to high-risk patients to improve the health and well-being of the patients they serve. To discuss One Program interventions more specifically, these bullet points cover integral opportunities for patient consultation opportunities. Number one, for patients that screen as high risk for opioid use disorder, discussing what medication misuse is and sharing with patients taking an opioid medication inappropriately or not following the prescribed directions is medication misuse, which is the first step to opioid use disorder, which then leads to the overpowering desire to use opioids, which increases opioid tolerance, and significant reduction in quality of life for individuals who suffer from opioid use disorder. Next, for patients screened as at risk for accidental opioid overdose, sharing with patients the comorbidity or concurrent medications that can lead to high risk of opioid overdose while using opioid prescriptions. Also sharing the signs and symptoms of opioid overdose, including shallow or slow breathing, blue skin, unresponsiveness. This leads to the next bullet point of explicitly sharing the benefits, availability, and dispensing of naloxone. This, of course, is coupled with information to the patient that a caregiver, spouse, partner, loved one also needs to be aware of what naloxone is and what instances it should be used. After discussing the importance of using opioid medications for the shortest period of time and the lowest dose possible to avoid adverse effects from the medication and also reduce the risk of opioid misuse, the next potential intervention is partial filling. Significant awareness over the past decade has brought attention to overprescribing of opioid medications, and we continue to see a significant downward trend in the amount of opioids being prescribed. However, we know that pain is extremely subjective from individual to individual, and patients may not need or want excessive amounts of opioid medication if they have concerns about the unintended consequences of opioids. This allows another opportunity for the pharmacist during that patient encounter to partial fill for a lesser quantity. In addition, for patients that screen as high risk for opioid use disorder or are concerned about what action steps they can take if they suspect themselves or a loved one with opioid use disorder, pharmacists can share community support services. An excellent example would be SAMHSA's website, where we can find links to providers and support networks for patients or family members facing substance use disorders. The PDMP is another tool in the pharmacist toolbox when navigating opioid harm prevention opportunities, discussing with patients the PDMP results and advising patients that may be using multiple providers, the risk for drug interactions, elevated morphine milligram equivalent, the substantial risks associated with this pattern as it pertains to opioid overdose events. And lastly, our medication take-back opportunities to share with patients. Of all the individuals in the U.S. currently diagnosed with opioid use disorder, roughly 50% of these individuals initially started using a prescription medication given to them by a friend or a family member. This points to the important practice of proper disposal of leftover opioid medications so they do not lead to misuse by the individual that they were prescribed or another individual that was not prescribed the medication. Options include informing patients about the MedSafe or Med Take-Back blue box located in pharmacies for disposal, or at-home disposal options, including DisposeRx packets or Deterra bags. Many states have allocated state opioid response dollars to disposal products for distribution to alleviate leftover opioids in the household. Department of Health and Human Services provides these to individuals and or pharmacies at no charge to share with the community. If your pharmacy has not taken advantage of this opportunity, I strongly suggest reaching out to your Health and Human Service Department to inquire about such resources to share with the patients you serve. Our last slide discussed potential interventions pharmacists can share with our patients focusing on opioid harm prevention, which transitions into our next topic, the One Program Triage Tool. The Triage Tool was developed by the One Program team and assists with when and how these interventions can be delivered during the consultation and patient education process. The Triage Tool has proved to be extremely helpful when navigating conversations with patients and discussions of interventions. If we start at the bottom left and move to the first box on the flow chart, we start with the assessment of whether the patient was screened as high risk for OUD, which would be indicative of the ORT being 8 or greater, or whether the ORT was less than 8. If the ORT was 8 or greater, we move to the box directly above to review if any red flags were apparent, if the PDMP raised concerns, and then using our professional judgment on our next steps, focusing on patient safety, education, and the potential for further discussion with the prescribing provider if warranted. In addition, we can continue to the very top bubble or box of this flow chart, which then leads to the N, the C, and the P. Counseling on the benefits and availability of naloxone. Counseling the patient on the option of partial filling the opioid prescription, and proper methods for medication disposal when pain management is complete. And lastly, educating the patient on the high risk for future development of opioid use disorder and community support services. These conversations are extremely important to bring additional awareness to the patient. However, the discussion surrounding OUD may be challenging to have with patients. Some strategies to assist in navigating these conversations that have proved to be successful include, first, using the screening form results and ORT to describe the risk for OUD. Pharmacists have expressed positive experiences in which the screening form was a valuable conversation piece with patients in broaching the topic of OUD. A second strategy includes educating the patient of signs or behaviors of opioid misuse, which is the first step in developing OUD. A straightforward description of what misuse is, for example, sharing with the patient that taking a medication for symptoms other than what it was originally prescribed for is misuse, or taking medication at higher doses or shorter intervals that what was originally prescribed are signs of misuse and can be a discussion point to both introduce the habit-forming nature of opioids, the long-term risks, in addition to better educating the patient and improving awareness of opioid medication risks. If we navigate back down to the lower left center portion of the box chart and start again with the ORT box, we can continue to follow this to the right if the ORT is less than 8, which would indicate a low risk for OUD.
However, continuing to use our tools in our pharmacist toolbox in assessing the PDMP and professional judgment to contact the prescribing provider if red flags arise. If we continue to the right, then we use our screening results to determine if any concurrent medications or medical conditions may predispose the patient to overdose risk, and proceed to educate and recommending naloxone and counseling the patient on opioid prescription pearls, including the option of partial filling the opioid prescription, proper methods of medication disposal when pain management is complete. Some conversation starters when discussing overdose risk with patients may include, first, asking the patient if they are familiar with the benefits and availability of naloxone, and if this was discussed with the prescribing provider at the office visit. Another conversation starter would be sharing with the patient what medical conditions or concurrent medications predispose the patient to be at risk for accidental opioid overdose risk. This again would be using the one screening form as a conversation piece to further communication exchange between the pharmacist and the patient. And a third option when initiating this conversation may be to share the risk of overdose and the signs and symptoms of an opioid overdose event with the caregiver, partner, and spouse during the encounter at the pharmacy, or encouraging the patient to share this information with their caregiver, partner, or spouse at home, as this will be essential information for the caregiver to take action during an opioid overdose event.
Next, I'd like to review our completed one program screening form from our mock patient and review the outcomes worksheet that identifies what interventions and education was shared with the patient and what details of this encounter is documented to complete the one program process. As a refresher, this patient had an ORT score of 10, which is categorized as high risk for future development of opioid use disorder, and also an overdose risk with concurrent use of both a benzodiazepine and either gabapentin or pregabalin. Starting at the top row, we would select yes to the patient was identified as high risk for opioid use disorder, and this was discussed with the patient. Next item would be categorized as yes for also indicating a risk for accidental opioid overdose. The third row identifies that medication take-back was introduced to the patient for any unused medication after they completed their pain medication therapy. The fourth row is indicating whether the prescription was partial filled or not. Of course, this encounter would be dependent upon the medication and the quantity of the prescription, and also the discussion of this option with the patient. The fifth row asks if the pharmacist discussed opioid use disorder with the patient, and yes should be acknowledged since the patient's ORT score was 10. This intervention is extremely important that both the risk of opioid use disorder is explained and also what OUD is and the habit-forming nature of opioids that were prescribed. Of the 9.2 million individuals aged 12 years and older in the United States that are suffering from opioid use disorder, 88% of these, or roughly 8 million, use prescription opioids exclusively, as compared to 6% that use illicit opioids and prescription opioids, and roughly 5% that use illicit opioids only. This is why having the conversation about OUD is extremely important, in that opioid use disorder is not an illicit opioid problem, but in contrast, it's mainly driven by prescription opioids that significantly reduce the quality of life of our patients who develop OUD. This conversation should be coupled with the next intervention of sharing community support and treatment services if themselves or a loved one is recognizing signs of medication misuse and loss of control overtaking the medication. The next three interventions are focused on naloxone, asking if the pharmacist discussed benefits of naloxone and identified the need for naloxone, which would certainly be warranted since this patient is at risk for accidental opioid overdose from the screening results. And the third intervention or row is directed at whether naloxone was dispensed to the patient, which of course is dependent upon acceptance of naloxone and whether the patient already had naloxone at home from a previous pharmacy or provider encounter. The second to last intervention is the prescriber was contacted, which may be appropriate after discussing with the patient if the patient feels comfortable with the medication being prescribed, after discussing the risks of opioid use disorder and overdose, and also if any concerns were apparent after reviewing the PDMP. If multiple providers were identified on the PDMP, the patient was educated on the association of using multiple providers and the inherent risk of opioid overdose risk with this pattern. In conclusion of this one program module, the one screening process has continued to result in positive feedback from both pharmacists and utilizing a tool with a high level of utility and fidelity, and also from the patient perspective, with a very high rate of acceptance in completing the screening form and the ensuing conversations to improve their well-being with the pharmacist. Of the screenings since inception of the one program, over 20% of individuals are categorized as at risk for opioid use disorder and or opioid overdose, or roughly 1 in every 5 patients. Over the past 5 years, the ONE program has continued to review best practices and current evidence-based recommendations for opioid risk screening and harm reduction interventions. To ensure that pharmacies are using the most accurate and effective risk screening resource for their patients, we felt that the changes described in these 2 modules were warranted. We applaud the efforts of pharmacists embracing the ONE program screening process and continuing to fill the position of opioid harm prevention stewards. Thank you for your time participating in the ONE program educational modules.